traditional drug treatment programs have many requirements often that make it challenging for people to initiate or be retained in treatment. And so models of care that include mobile treatment, integrated care with harm reduction services, and low threshold models have really been successful at increasing uptake of buprenorphine and other treatment engagement, and especially among marginalized groups. Next slide, please. So in 2016, I was, as Barbara said, I was the HIV hepatitis C medical director at the city health department. And at the time, our mentor, Dr. Kathleen Page, was also working at the city health department, and we had an opportunity to receive an old mobile clinic that was gifted to us from another program. And so really tasked with thinking about how we could best utilize that truck, we decided to focus on the overdose endemic. And we drew on decades of experience that the health department had in community risk reduction services, including syringe exchange, delivered in a mobile fashion, as well as our sexual health clinics, to really kind of marry together a package of services designed to meet the needs of people who use drugs. Our work is grounded in humanism, social justice, and harm reduction, and we aim to reduce health disparities and improve wellness by providing a continuum of low barrier, stigma-free services in the community, really focused on meeting the needs of people who use drugs and people experiencing homelessness. Next slide, please. So here is a current display of our current schedule, which has evolved over the last many years. Our initial locations were chosen sort of looking at data around high utilization of syringe service programs and overdose. And we really started out kind of parking next to our city's syringe service vans. We've recently, in the past few months, kind of consolidated some of our locations, and we now visit 4 sites across the city. We generally have between 4 and 8 staff members on site at any given time, depending on kind of what our schedule looks like at that particular location. And due to both our small team and the comprehensive nature of the work that we do, our staffing model is really grounded in like flexibility and malleability, and people kind of doing a lot of different roles. So our community health workers do phlebotomy and rapid testing and drive the truck, and our case manager drives the truck. Our nurses kind of do everything. Our providers do registration sometimes, and so we all need to do kind of a variety of roles just to keep the clinic running every day. We also attempt to maintain continuity and communication with our patients, which we've really increased our ability to do after sort of our experience during COVID and our success with maintaining some patients on telemedicine. And so after that, we've really made a concerted effort to have a phone number that anybody can call and get an answer, or text us and get a response. Knowing that a lot of our patients don't have access to phones, but when they do, it may be the only moment in time that they have access to that phone, and we try to be really responsive to those connections to keep people engaged in care. Mobile health is also about partnerships, and we currently, I mentioned that we partner with our city's syringe service trucks, but we also partner with other community-based harm reduction organizations for bi-directional referrals. And in particular, right now we park at Charm City Care Connection, which is a harm reduction drop-in center, 2 days a week, and have a really strong working relationship with their organization and staff. We also go with their team on a more street-based outreach around the city to sort of capture folks who aren't even coming into the center or to the truck, to provide really mostly wound care, but a lot of the sort of medical triage and trying to increase referrals back to our truck and the drop-in center for more comprehensive services. Next slide, please. So I've kind of described what we do, but really treatment for opioid use disorder with buprenorphine is the primary service, and really what more than 80% of people come to us for. We do also have folks that come to us just for testing, just for hepatitis C treatment, or just for vaccines sometimes, but primarily people coming and requesting buprenorphine. The other clinical services that we try to offer everybody as the standard of care when they're coming into buprenorphine treatment is rapid HIV and hepatitis C testing. We offer sort of immediate blood work for anything that's positive, and offer rapid ART initiation for HIV. We offer PrEP, hepatitis C treatment, testing and treatment for STIs, wound care, including antibiotic management needed for skin and soft tissue infections. We also started screening for depression and providing some basic depression treatment. We do vaccinations for, usually we have COVID, flu, and hepatitis A and B. We also hand out naloxone and provide education on that, condoms. And now when we're at a location where we don't have a harm reduction partner, we also do our own syringe distribution. We also have a case manager who is pictured there in orange, who is able to kind of ensure, help ensure insurance enrollment, any other support people need in terms of getting vital documents, linkage to primary care and mental health care, and support with housing, case management. We also recognize that aside from the list of things that we have there, there's a lot of need that people have in terms of care coordination, some urgent care, hospital discharge coordination, and things that we try to fill in the gaps as much as we can, despite the fact that we don't kind of offer a full package of primary care services, because a lot of most of our patients are not engaging in a regular healthcare primary care services elsewhere. Next slide, please. So since the beginning of our program, we've served, I think we're getting close to 2,500 patients. When we looked at our first year and a half of services, we found that patients receiving buprenorphine were more likely to get tested for HIV, Hep C, and STIs, and more likely to be treated for hepatitis C. And patients who were receiving hepatitis C treatment and patients who were Black or African American were more likely to be retained in our buprenorphine treatment at 3 months. On this slide, you can see just a snapshot of our service utilization in the calendar year 2023. Each year over year, we see an increase in the number of patients that were served. We've also made a number of modifications to our program to try to increase retention in buprenorphine treatment, which in the first year and a half of our program was less than 30%. And when we looked at an update to that last year, we'd improve our 3-month retention in buprenorphine to 60%. So we were pretty excited about that. However, homelessness, overdose, violence, poverty make every day a challenge for our patients, and we continue to strive to do more to accompany them through the healthcare system and through their path to health and wellness, which often can feel kind of overwhelming, given sort of the size of the struggles that they have. Next slide, please. This is just a snapshot, just to give you an example of our hepatitis C testing and treatment care continuum. This is also something that we recently published, looking at sort of a year and a half of people who came into hepatitis C testing. And despite what I feel like are our best valiant efforts to sort of really minimize the barriers that people have to getting treated for hepatitis C, there's a number of challenges that remain, including just simply getting blood work, phlebotomy from people with difficult venous access, insurance requirements and prior authorizations, navigating like specialty pharmacies, and patients' life barriers that often lead to them prioritizing other things or having difficulty maintaining medications safely. And this graph you can see is divided by housing status as well. That really people experiencing homelessness, particularly people who are unsheltered, is much more challenging for them to kind of maintain their medication adherence. Next slide, please. So our it's just some basic challenges that I think a lot of mobile programs struggle with, is that our program has been funded by a patchwork of state and federal grants, most of which are short-term. So sustainability and growth of the program is always a challenge. And I think That in addition to the fact that I've sort of alluded to, there's just these really significant needs and gaps in the service that we're able to deliver compared to what people like really need to get on a path to health and wellness. Just is a constant challenge for us to try to meet our patients' needs. Next slide, please. And so lastly, just some of our take-home points is that our program is really, we try to always have a foundation of just humanism and harm reduction and patient-centeredness in the care that we provide, flexibility and accessibility, and integration of services as much as possible is how we try to sort of work towards that continuum of care that people really need. I found that really providing what people want and need first and focusing on their priorities helps us also then bring in these other components of hepatitis C treatment and STI testing and things that are also of public health impact. Linkage to other services we found to be really challenging, and we over time have tried to build our capacity as much as possible to do things on site for folks, which, you know, for example, screening and treatment for depression, because we found that linking to mental health services was such a challenge for us. Partnering with community organizations who are trusted in the community that you intend to work in is just kind of essential, I think, in order to really start with foundation of trust when people are coming to you for services. And then lastly, as a clinician and anyone else who's out there, I think building your own skill set and organizational capacity to provide additional services for people if your organization isn't already doing it. Buprenorphine is amazing, saves lives, relatively easy to prescribe, and wound care is very needed, especially in the age of xylazine, and it really helps build trust with patients because it's really a priority of a lot of patients who have chronic wounds to get that service, and you can sort of build rapport and kind of work towards other health goals at the same time. And lastly, please be open to treating people, the hepatitis C and people who are actively using drugs. It's the only way that we're going to get Hep C elimination in this country. All right, that's it. Thank you. I have an extensive list of references in here as well, which includes publications about our program as well. And I will stop there. I'm happy to take questions now or later, however you all want to do that.
Yeah, I think we were going to have Trish talk, and then it'll be the rest of the time is all questions and discussion.
Great, thank you for that. Let me see if I can share. Can you guys see that?
Not
No.
yet.
Nope. Let's see here.
Also, while you're getting set up, I was just going to tell everybody, we are in meeting format, so you'll be able to like raise your hand and unmute if you want to just talk. But if you want to ask a question in the chat, that is also perfectly fine, especially like if you're thinking of something right now and are worried you'll forget it 5 minutes from now, if you're like me. So.
Okay, here we go. Now, can you see that?
Yes.
Yes. It's kind of a mess, but now it's full screen. Okay, here we are. Hi, I'm Trisha Ackery. I am a family physician and executive director of Courage Medicine. A lot of what I'm going to talk about is very true and similar to what has already been shared by our first speaker. These are some pictures from Philadelphia and sort of, you know, give some color and some frame to the problems that, you know, we're all facing in large cities with large populations of people that are unhoused, people who are actively using drugs, and people who are the focus of our housing, of our outreach programs. This is an article from the New York Times that sort of described the problem as well, that was published a few years ago. But, you know, it's very similar to what we've already sort of talked about with the overdose epidemic and this endemic of being unhoused, substance use disorders, and infectious diseases that are related to the use. And so this is kind of some data that is also very similar. The interesting thing I think about Philadelphia that's kind of perhaps different from other places, I don't know, is that we are very siloed neighborhood wise. So this is the map of Philadelphia, the whole county, but it's split by neighborhood and zip code. And then they ranked all 46 zip codes by health outcomes. And so the two places that we focus most of our work are in Upper Kensington, which ranked 46 out of 46 districts in health outcomes, and then in Southwest Philadelphia, some of which is actually suppressed, and isn't colored at all. But the Paschal King-Sessing region is demonstrative of similar, very poor health outcomes in general. The other thing is that the districts also sort of follow the same kinds of patterns in terms of numbers of overdose deaths by location. And then lastly, bottom left, that chart from the city of Philadelphia shows that numbers of HIV infections amongst people who inject drugs were dropping from the early 2000s until the advent of fentanyl in our drug supply. The number of HIV infections started to turn back up again because people were having to inject more frequently and more exposure to HIV infection. Another thing I should add too about sort of the culture of use in Philadelphia, and something that sounds like it's quite different from Philadelphia, is that we have one needle exchange program. It's large. It has recently lost its city funding, and so its syringe exchange is not quite as accessible as it sounds like it is in Baltimore. So a couple of things about substance use, as it sounds like a lot of you may already know, is that because people wake up in profound withdrawal, we really need to provide services right near where they are. Folks can't really travel very far from where they're using their drugs. There's also a lot of tight relationships that are formed amongst individuals who use drugs, who inject drugs, because of stigma, because of perceptions of the rest of the community. And they experience stigma, and they have come to trust each other. And so those community relationships and bonds amongst individuals who are using substances together are very tight. We have found that was a key thing that really led us to want to be providing mobile treatment. So I founded Courage Medicine in 2019, and right after that, the COVID pandemic hit. And so when I started out, it was me and a psychologist. I'm a family physician, and we were really on foot, and we were going around the streets of Kensington, finding people. And then, when COVID hit, we really started relying a lot on telephone and telehealth. Basically just really low barrier buprenorphine to prevent overdose and to prevent death. Demographically speaking, our analysis has been that approximately half of our patients are homeless, 75% actively inject drugs, and we have high levels of individuals who participate in sex work. So in sort of that backdrop, we purchased a retrofitted recreational vehicle shortly after founding Courage in 2020, and we have been providing STI testing, treatment, medications for opiate use disorder, HIV and hepatitis treatment, harm reduction services, as well as what we call care management. So our care managers are typically master's level psychology or social work professionals who provide individual therapy to our patients. We don't generally call it therapy because people aren't always interested in individual therapy from a psychological standpoint. So we've used the term care management. It also sort of matches up with our designation as the Center of Excellence in Pennsylvania for treatment of opiate use disorder. Care managers are also trained to manage chronic conditions, chronic disease. And so the care management role blends psychology, social work, and coordination of care for chronic medical disease. Generally, we always have at least 2 people when we go out in teams now. Typically, it's more 3 to 4, and we also train graduate students in psychology and social work programs around the Philadelphia region, and so they're often with the outreach team as well. There's always someone who can perform phlebotomy and rapid testing so that we can do the STI testing and rapid tests for HIV and hepatitis. We also use rapid tests for hepatitis B, gonorrhea, chlamydia, when folks don't have access to insurance coverage to pay for the blood draws. And then lastly, there's a medical provider who's available. One thing COVID really taught us was that we could use telehealth pretty fluidly to see patients. And initially, when we went out in Kensington, I was the provider and I was on site, and we were seeing sometimes as many as 60, 70 people a day who were coming for Suboxone treatment. And we learned pretty quickly that it was good to have a backup medical provider when it was that busy. And then that person could meet with someone over telehealth. So we outfitted our, what we call the mobile testing vehicle, MTV. We outfitted that with Wi-Fi and made sure that we had a laptop on board. And similarly to the previous speaker, we have cross-trained most of our staff to do all sorts of things. So as a provider, I would have to register folks. The care managers do all sorts of things. Most everybody's trained to do rapid HIV tests. There's a lot of cross-training that happens among different disciplines. Very flexible is definitely the word. Definitely the word. So we've done quite a bit of community outreach in a variety of venues. I think building partnerships is really key. This is one iteration of our team at the Puerto Rican Day Parade in Philadelphia a couple of months ago. I think getting out into the community and looking like the community members that we're serving are really important things too that we've found are super helpful in building partnerships and relationships. We like to use a lot of fun sort of props and things. So these are some props that our team made for participation in like a street festival that was happening in West Philadelphia. In 2024, we have been able to provide many, many tests for syphilis, gonorrhea, chlamydia, HIV, hepatitis. We also provide buprenorphine, as I mentioned, and wound care is definitely key as well with xylazine in nearly all of our dope supply at this point in Philadelphia. The wounds can be quite difficult to manage. Over top of what we were doing in terms of funding from the city with our mobile treatment, we then applied for funding from the CDC through the ESHE program to form our sexual health clinic for anti-oppression, gender affirmation, and empowerment. And through that program, we've been able to provide even more services, including sexual health services, HIV prevention. We really make a big effort to start people on PrEP and are planning to do even more of that in 2025 going forward. This is just a list of some of our funders to say thank you and recognition of them. And I wanted to spend a little bit of time talking about one particular patient that we've been really proud of taking care of. So Missy is someone that we met in late 2023, and she first tested positive for pregnancy in November of that year. She's 32 years old, and she's largely unhoused and stays in different parts of the city. So being mobile, being flexible, being able to go to different parts of the city with services on the MTV has been really key in taking care of our patient population that is really very mobile. One of the things that we really prided ourselves on with Missy and with many other patients that we really have taken care of is that we were really the only provider that she was able to consistently engage with. Another big piece of what we really do is use health education navigators. Some people call them peer navigators, recovery specialists, people who are from the community where we're working, people who have lived experience with the situations that our patients are in, and people who can really connect with them on a personal level. Missy is someone who engaged in sex work throughout her pregnancy to support herself. We were testing her frequently. We were treating all the STIs. We provided her with Suboxone and medications for withdrawal, and we're able to really keep her in care by providing a wide variety of services from one location in one mobile service. I think that's been one of the big important things that's made our program successful. We also have a really active social media presence on Facebook and Instagram and all the other regular ones. These are just some of my favorite campaigns that we've had. We use like a lion as our logo, and so the sage, that's the sage lion for our sexual health clinic specifically. And that's all that I have for now, and I'm happy to take questions.
Great. So while folks are getting themselves all together, again, you can do the chat if you want, or if you want to raise your hand and we'll pluck you out of your square and you can just unmute and ask your question. While folks are thinking, I know at least one other clinical program is on here that is trying to set up their mobile health unit, their van. What are some of the kind of early in logistics that you found as far as like finding a lab? What are the like legally like what staff like needs to be for what thing and who super like all those kind of nuts and bolts things? And either one can go or both.
I mean, I think that's a really, really big, huge topic of conversation and really sort of, the gist of why this is difficult to do, I think. For our program, we sort of did these things because we had to, because we didn't have a physical location that was close to where our patients were staying and using drugs. We didn't have sort of physical clinical resources to do the work that we saw people needed to have. People weren't really willing to come inside to a clinic in any way for many reasons, because of COVID, but also just because sometimes people who are unhoused are just very anxious about coming indoors. And so we sort of did it out of need. I think, the thing that we found really important is to have someone on the MTV who can take blood. That's one thing that we sort of feel like we sort of can't function without a phlebotomist. We've cross-trained others of our staff who aren't necessarily phlebotomy trained to do rapid testing. So those are the things I think. Wound care is something else that's really important to have, I think, on site as well. And then access to a medical provider. And for a long time as a physician, I was the medical provider for the first couple of years that we were doing this. And over time, we've hired a number of nurse practitioners who've been able to provide those services. I think that that's really the key team that we need. The other thing that we've found to be really useful is to have behavioral health specialists with us on the street. And so, using motivational interviewing, using some basic individual therapy techniques and other things, that's the connection that patients build with the team is with that, that's their person kind of. And so I think that's been really useful for us to have those behavioral health services right on track, right there too.
Yeah, I agree with everything that you said, and I wish that we had behavioral health specialists. But I think that like just the theme of having people cross-trained and trained up as much as possible to provide the essential services that you're offering, because if you only have one person who can do phlebotomy, if they're out that day, are you going to like not provide that service to people when they come, right? So having some redundancy in what people can do to be able to fill in for each other is really important. And I would say also thinking about how, as you build out like lab contracts and other things, like how you're able to provide services for people who may be uninsured. Our program is fortunate to kind of build our services out from our health department, sexual health clinics, who had a lot of infrastructure for labs and things in place. But, we have a lab, a contract with a commercial lab that allows us to provide lab services for people who are uninsured. And that's part of the contract that we have with them. So that, if somebody wants hepatitis C treatment, we can get all their lab work, and that's not going to be a barrier for them. For our buprenorphine prescribing, we also have written into some of our grants to have funding set aside for people who are looking to get on buprenorphine but may not have insurance that day. Most of our patients are Medicaid eligible, and we may just need to go through a process of sort of getting them enrolled in Medicaid. But if they come to us without insurance yet, we cover the cost of their medication until they can get their insurance active. So that's really key, because in that way we can be sure that we're not having to turn people away, as much as possible. Two other points I wanted to make is, one is that when our program started, we didn't have a lot of staff, and there was just like me, another provider, and like a community health worker. And so we were always like inside the truck when we were parked at a place. And now we have more staff and ability to have people outside of the truck. And I actually think it makes a really big difference in our ability to like engage with people on the street. So like, it's part of our practice now to like always have tables set up on the outside of the truck. Which has, I think, really improved our, engagement with people. And then lastly, and I said this in my talk, I think having partnerships with other organizations and people doing work in the community is really huge, as you're sort of thinking about where you're going to go and how you're going to start engaging people.
Yeah, I echo all of that. And having a tent in case of bad weather is also important. That has come in so handy.
Portable heaters, we have generators to run our heaters outside. Like, it's a whole operation in the winter.
We have these tents too that are just like fit two people kind of, and they just zip down. So it's like a private space.
That's nice.
Do an HIV test, to talk about results, things like that are
There's several questions about rapid testing for gonorrhea, chlamydia. Like what type you're using and what's the turnaround time.
Yep. So there are two different kinds of rapid gonorrhea chlamydia tests that we use. One of them we've been able to get commercially in the States from our medical supplier that we use, that requires electric plug-in. That's like this case that you insert the specimen into. That one takes about 20 minutes to run. And is only approved for use in people with female genitalia. And so it can't be used for male specimens. The other ones that we have procured are ISO approved, which is which is a WHO designation of certification of lab standards, but they're not approved in the US. And we get those from a website that I'm happy to share called headstartlabs.com. Bulk test kits, www.bulktestkits.com. And they are more like a pregnancy test where, they take like 3 or 4 minutes to run, just like a pregnancy test would, where you put the specimen in the one side and it runs across, and they're pretty quick.
Bulk test? How do you spell that?
Bulk,
Oh, bulk.
BULKTEST kits.com, all one word.
Okay.
Yeah. And they've been responsive. It takes a little while to get here because they come from New Zealand.
Here's another question from Sarah down in Kentucky at Matthew 25. How do you break, and this is either one of you, how do you break barriers to access to medication, HIV medicines, PrEP, STI, for those that aren't housed or have reliable transportation to go to pick up medicine at a pharmacy? Do you use your mobile transport vehicle for medication access?
What we've done really is partner with pharmacies that are in the neighborhood. So there are 2 pharmacies that are really close to where we had been parking our MTV, that are very responsive to our patients. They're very open to seeing our patients. I think that's another important piece of this, is really partnering with community members who are open to taking care of our patients. We do carry samples of PrEP and ART on the MTV with us, that we get from the drug companies as samples. And so we always have those for the first week or 2 weeks of supply if needed. In terms of STI medications and things, with SSHI funding, we've been able to get access to 340B, and that's helped us to purchase some of those medications as well for folks that aren't insured. We also just pay out of pocket for some of them because they can be pretty inexpensive sometimes, depending on what it is you're using.
Did you say you got access to 340B by partnering with another location?
No, because of our CDC funding.
Perfect. Okay.
Yeah, our SSHI funding. Yeah.
To what extent do you use the 340B?
Quite a bit. I mean, we've had 340B access for about a year now, and it's a decent revenue stream for us. I don't know that we've maximized it yet, but I think it's in every agency like mine that I've ever worked in. It's been really important to, now of course with federal questions around all sorts of things, we all have to continue to think about access to those types of programs. But for now, I would say that's, a pretty big driver of our finances.
And I would just, I would echo that. I think we do very similarly. Every location that we go to, we identify pharmacies that people can walk to from our truck, and kind of partner with them. And it's really important for buprenorphine access as well, because there's a lot of pharmacy level barriers for buprenorphine. Not all pharmacies stock it. They have these like perceived quotas that aren't like real in terms of like how much they can get without sort of like red flags from the DEA and things like that. So there's like a lot of just access issues. And so we've been lucky enough to find enough pharmacies that want to work with us, and who like the pharmacists will be like texting us like directly if I'm going to be out of Bupe today, so that's super important. We also carry sample packs of ART and PrEP. And we always bring out medication to treat STIs. Again, that's part of the benefit of our sort of extension from our health department sexual health clinics, and including Vicillin. Although we can of course prescribe medications too if that's appropriate for a patient. And then we also, for our hepatitis C treatment, we've always partnered with the Johns Hopkins specialty pharmacy, where if we're prescribing hepatitis C treatment for somebody, we'll work with that pharmacy to get the medications delivered directly to us and bring them out to our patients. There are some community pharmacies that kind of manage those medicines as well, but it makes it more accessible to folks, at least in Maryland. And with our Medicaid program, a lot of the hepatitis C medicines are managed through these specialty pharmacies that like if we weren't in the picture, like this patient would have to talk directly to this like specialty pharmacy and get medication delivered to a house. And like those are not things that our patients can typically like manage. So so we do kind of deliver the medicines out to them. And then if there's an issue, if they have trouble kind of having a safe spot to keep the whole pack of medicine that we're giving them, we can just give them 1 week at a time or whatever kind of works for them to better manage the medicine.
And
In terms of the question in the chat about limited space and storage, I can speak to that. We found that in terms of providing services, from a certain number of hours per day, that you have to really leave an hour or two at the end of the day for cleanup and putting things away. So things that can't stay on the MTV, particularly in the summertime when it's too hot, like medications and test kits and things like that, we keep in like a bin that is easy to pick up and sort of put into an indoor space, where we park the MTV, that kind of thing. And there's some things that need to be refrigerated. Our refrigerator in our van only works when the engine's turned on because it's propane. And so, right, those types of things you have to take out of the fridge. And that's been one of the things that we've sort of struggled with in terms of vaccinations. So I'm impressed to hear that you guys are doing that, because our fridge isn't great. With a retrofitted RV, it isn't medical grade, so we don't have a great refrigerator on board either, but we were able to use specific coolers that are made for that purpose, that you deep freeze the blocks, and then the freezer maintains the temperature to keep the vaccines. And you can use like a continuous temperature monitor to make sure that it doesn't get out of the range that the CDC requires for vaccines.
Yeah, 100% all the same. We have the same bin system. We have the same, like, there's an elaborate schedule of like the van is parked in one place and like somebody else has to go to the health department to grab our bin of things and the stuff from the fridge. We also now have it for vaccine purposes, although it's not like ideal. We have a plug-in, like a Lion cooler, which can maintain, so we can bring it onto the truck, because again, the fridge on the truck isn't sort of the grade that you would use for your vaccine storage. So we can plug our cooler in on the truck and kind of maintain it in range, although ours has been like wildly out of range and beeping at us all the time, so it's been a problem. But that's how we do that. But it's a lot, because you have a lot of supplies to bring out every day. We also, and I didn't mention this, but we also make snack bags for our clients, which is huge, and is a lot of effort goes into packing snack bags and bringing big bins of snack bags out every day, and we don't leave them on the truck either. So it's a lot of supplies every day and all the tents and heaters, and
it takes a village.
If there's not, I don't know how many more questions are in the chat. Is it okay if I ask one live?
Go for it.
So, hi, I'm Sai, Executive Director at Ashwell, based in Austin, Texas. We serve Central Texas from Austin straight down to San Antonio. We are doing a lot of Hep C work. We were some of the first ones doing kind of like, wraparound care in the way that y'all are doing around Hep C in San Antonio, and trying to get it started in Austin as well. We got our first mobile unit last year in 2024. She's called Ashwell on Wheels. She's really cute, but we also are struggling with how do we do all of it's really just like we're at the place where we're building all the infrastructure now. So we've been working with partners. We're partnered with a couple of methadone clinics down in San Antonio, which has been nice. But we have like very specific like infrastructure questions. So the first one is, how do y'all navigate scheduling, like walk-in scheduling versus like clinic services intakes and labs? Do you make appointments? Like, what is your approach, and what's the best approach to actually engaging people at these sites?
We have 3 physical locations plus our mobile treatment vehicle, and all of our schedules are open access. We don't schedule any appointments for any of our locations. Okay. We found that people cannot keep an appointment on Tuesday at 3:00. They need care now. The motivation window is very small, and they're in front of you and you have to do the thing. So everything we do is open access.
Well, how do you manage all the walk-ins too? Like, is it short appointments, or how does it work? Literally?
Yeah. So I mean it's literally walk in, and it's difficult, particularly when I was the only provider for a long time.
Yeah.
That's why having our behavioral health staff is important. If people are out of hand, someone can take them aside and sort of like take them down and just talk to them quietly, give them a snack, things like that. It takes, I say we have at least two people, but more typically when we're really in Kensington doing this work, right now we have a storefront location, so we're indoors. But when we were doing this outdoors a year or two ago, we had 8 people with us on site to do this kind of stuff because, there was just a variety of different needs constantly.
Yeah. Yeah, yeah. And then people just wait. So it's just first come,
Yep.
first. It's right there.
Yes.
And that's
We
it.
would keep a list. I think Kay just joined. She's our coordinator extraordinaire. I don't know if she wants to say a couple words, but yeah, we keep a list of when people show up in the order.
Yeah, I was the bouncer and coordinator. Just like managing the personalities. And I mean, I think that, Trish mentioned something earlier that I think is really helpful, and that some patients do better in a mobile outdoor setting. We've definitely seen that now that we have a storefront. Some folks struggle to come indoors. They feel closed in, they struggle with their anxiety, their trauma. And so at least outdoors, they are allowed to go down the block and have a smoke and move around and have a level of freedom and independence that is so helpful. So
Thank you. Thank you.
For us, we do, so we don't pre-schedule any new patient appointment. It's all sort of walk up, first come, first serve. We typically have sort of a cap on our total number of new patients for buprenorphine because for a while we tried to just like not turn anybody away, and our panel size got completely unmanageable. We were seeing like almost sometimes in the 40 to 50 patients a day in like a 5-hour session, which was unmanageable. So we usually take like 3 at least new patients for buprenorphine services, first come, first serve. And then we do have a schedule of people coming back for follow-up, usually for their buprenorphine. So we know who to expect and when their medications, due. But it's not a scheduled time. It's like you're going to come see us on Tuesday. You can arrive anytime between 8:30 and 1, as long as you get there before we leave, we'll see you.
Just a window of the
Yeah,
whole
it's
time.
just a window. It's first come, first serve. Sometimes people have to wait a little bit. But having more than one provider on site is helpful to kind of manage whatever kind of influx of people that you have. In our model, any provider can see any patient. So it's not like I have my panel of patients and my other provider has her, it's like you just see them in the order that that they come and who's available to see them. It breaks down the continuity of some people a little bit. So we, sometimes we have special patients that we try to like, direct to the provider that they've been seeing. And I will say also, like, for any patient of ours who's like been a patient of ours and they come back and they weren't scheduled, like we always fit them in, like we don't turn them away. So
And what does it take to get to the I can never say this, buprenorphine? How do you get to that place? So we have NPs and we have RNs, we have MAs too. And we're trying to just cross-train all of them to be going out to the mobile unit. We have, our facility as well. We have a clinic. But how do you get to that place? Like, can any NP go ahead and what do you have to do? What do you have to do to get to that place where you can prescribe this?
well, luckily, we're in a place now where there used to be an extra training and X-waiver requirement, and that has been removed such that if you have a DEA license, you can prescribe buprenorphine. I think building capacity and comfort level with prescribing buprenorphine is like another question, and and having somebody who's there, who's like championing it, who's like overseeing the work, and like consultants that you or people, experts that you can consult in your area who can kind of help troubleshoot questions is really important. In Baltimore, we also have this like network of people who are interested in providing low barrier buprenorphine, and there's even like a listserv, so we have like a lot of communication across the city for people for capacity building purposes. But from just a requirement standpoint, if you have a DEA, you can prescribe.
Thank you. Do y'all use, what EMRs do y'all use? Because I heard you all say you put the laptop on there. We do that too. We use Athena. We get people just built in right to our into our system. It sounds like you're working with primarily folks experiencing homelessness, so probably a little different than our demographics. But I just wonder, like, what EMR are you using, and do they become patients, and go to your facilities after you engage them in the mobile unit, or is it you're using the mobile unit, you're going to these sites every, second Tuesday of the month or whatever, and they know you're going to be there?
Yeah, I will speak for us for Baltimore. We had a whole patchwork of old and integrate many different systems to make our system work, but we've now switched to the community version of Epic for our EMR, which has actually been really nice for us. And I will say when we started out with a mobile clinic, I think we thought that people might get started with us with the services and then transition to like another clinic nearby or whatever, and that hasn't been our experience. So we, in general, if people are coming to us, they're kind of getting their services with us. They don't tend to transition either to like our brick and mortar sexual health clinic or to other clinics nearby. That's sort of just our experience.
Wow.
I would say all of those things are true for us. Sometimes people only see us on the mobile unit. Sometimes they come to our brick and mortar. Sometimes they switch which location they come to. We're just open to all of that. We used Athena for a really long time and loved it. We now use a different EMR called MedGen, and I'm going to look into the community version of Epic because I would love to be able to use Epic.
It's called Ocean Epic.
Is it
What
not
is it called?
really expensive?
Ocean, I'll put it in the chat.
Oh yeah.
Oh, perfect.
We looked into that. I think they wanted us to pay like 200,000 up front, 250
Oof.
something like that. So we're not there yet.
No, we're
Yeah.
not either.
It was our whole health department went to this, so this for our mobile clinic. Yeah, that would be challenging.
I see. Well, we'll see.
Okay.
Okay. Well, I think we're getting up to Destiny. Are we keeping going, and those who have to drop off, or no? We are wrapping things up. Okay, so thank you. Destiny, did you want to say any final words, or am I saying our final words? Thank you everyone for coming. We anticipate having more of these e-learning communities for our SE and SHIPS funded clinics. This is just a great way, as you saw happen today, for peer-to-peer sharing on a lot of these logistical issues. Trish, I think, put her email in the chat if you need to just reach out directly. And yes, thank everyone.
Happy to share slides. Yes.
Will we
Thank you
get the
all so very
recording of
much.
this as well? The recording of the meeting we sent out or shared?
I'm sorry, could you repeat that?
I was wondering if the recording